Good morning. Welcome to the Department of Medicine Ground Rounds. Today we have a guest speaker who's been with us before. Barbara Casper will tell you all about that. This promises to be an exciting conference. But before that, a few comments. First of all, is Ruth Carrico here? The ID group usually sits in this corner. I don't see them here today. They may be in a meeting. Forrest Arnold is over there in the corner. Ruth Carrico, Associate Professor of Medicine within the Division of ID and Associate Founding Director of the Global Health Initiative, has just become President-elect of the Kentucky Nurses Association. So if you see her, congratulate her and help her bring some more nurses to our hospital. As usual, we try to remember events or people who have made some difference in the way we think about medicine and biology. So we want to remember today Dr. Richard Bright, who was born on this day back in 1789. You may have heard that term. Many people call him the father of nephrology. He describes Bright's disease or nephritis, but few people know that he was also interested in pulmonary medicine, abdominal tumors, heart disease, and so forth. So he was quite involved in multiple areas. Louis Pasteur died on this day. Louis Pasteur died on this day back in 1895. I didn't know, you know him as the father of microbiology. I didn't know that he was a chemist that originally started with tartaric acid. He was really working on the stereochemistry of tartaric acid. He saw the light and began to study stuff more relevant, I think, and found that bacteria actually was able to ferment sugar into alcohol, described that microorganisms were not able to come up out of non-living environment, and that was not known then. And so he helped our understanding of the germ theory for infections and ultimately how to kill them and ultimately the process of pasteurization. On this day was the death in 1927 of William Einthoven, Einthoven, just in case I didn't pronounce it appropriately. He was a Dutch physiologist who revolutionized the way we do diagnosis by describing the electrocardiograph. And that was back in 1924 when he received the Nobel Prize for that invention. And with that, I'll leave you with Dr. Barb Casper, who's going to introduce to you our guest speaker of the day.
So one of the advantages of being in an institution for nearly 20 years is that you have the opportunity to see your residents excel after they graduate from training. And it's an absolute pleasure for me to be able to introduce today's Grand Round speaker, who is one of our former residents and then subsequently chief resident. Ryan Hurt is originally from Rochester, Minnesota, and completed his undergraduate degree at Hamline University in St. Paul. Excuse me. He subsequently completed a master's degree in biology at Murray State University, followed by his MD here at UofL. He became a resident in our program and subsequently became a chief. And during his residency, he also completed his Ph.D. in physiology and biophysics. It's no surprise that he was recruited by the Mayo Clinic upon completion of his training, and he currently holds the rank of Associate Professor of Medicine there. Ryan has excelled as a faculty member, no surprise there, at Mayo. He is the director of the Home Parenteral and Enteral Nutrition program and holds a joint appointment in the Internal Medicine Division as well as the Division of Hepatology and Gastroenterology. Ryan's research interests include nutrition, obesity, and smoking cessation, and he has had continuous funding through the NIH and NCI during his time at Mayo. His research efforts have resulted in 75 peer-reviewed publications, numerous book chapters, and invited lectureships, such as this one. In addition, he continues to serve as a mentor for residents and students, and his efforts have been rewarded with multiple teaching awards. Most importantly, perhaps, Ryan continues to have active ties to our campus and still remains a loyal UofL fan. I'm delighted to introduce Dr. Ryan Hurt. The title of his presentation will be Identifying Nutritional Risks in Patients from the ICU to Home. Ryan?
All right, thank you. Thank you, Barb. It's truly an honor to come back. I used to sit, although it's remodeled now, I used to sit in some of those chairs when I was wasn't doing things on the floor. But it's an honor to be back. I changed my title just a little bit. And so since I got to Mayo Clinic, one of my interests was nutrition because of Craig McLean and Steve McClave, and they're in the audience. So I was approached eventually to take over this intestinal failure, world-famous intestinal failure program, and I felt totally not qualified to do that, but I took over that role, and that's really led to a lot of my academic successes up there. So, and trust me, I was a very average resident and sitting in your chair, and so if I can do something like this, sometimes it's just all about luck and timing, but I'm sure a lot of you guys can do the same sort of thing. So I do a little bit of consulting for Nestle. That's about all, and I work with their education. That's why I get to come back a lot to train our Nestle fellows that come here and rotate here. So that's pretty much all the consulting that Mayo Clinic allows me to do. So one of my first things to ask you guys just to think about as I'm going through this talk is, how many of you feel, a lot of you guys feel comfortable with hypertension, cirrhosis, cancer, various infectious diseases, but how many of you feel comfortable with malnutrition? And most of you are going to say, yeah, I don't really feel comfortable with that. And I'm going to show you why here in a little bit. So I didn't have you guys do clickers, so you just kind of click in your brain, but so what's the definition of malnutrition? And this is one of the problems that I'm going to talk about in my talk here. So the answer is pretty much all of these, and that's one of our problems in the nutrition world, right, is we have all these definitions of malnutrition. It is a very common problem, but we have no unifying definite definition. So my favorite quotes from residency at UofL. So Dr. Bornstein, which I learned in doing this talk that he had passed away, but he was my clinic, AIM clinic faculty, and so he would always say, when I would get off on all these tangents, he'd say, you have to clearly identify the problem, Dr. Hurt, before you can treat it. And so I really took that to heart, and that's part of kind of my overall theme today. My other one was Dr. App, who said it's easier to call a doctor than be a doctor. And that came from being on his service out at Audubon when everybody would be consulted, the hospice would consult us for a COPD, and I'd be like, Dr. App, I don't understand this. Why does a hospice need to, have us help with COPD? And he just looked at me and said, it's easier to call a doctor than be a doctor. So I'm just going to run through a few kind of little bit history of my time here at UofL. My first month was with Rosemary Yusuf, who is now at SLU. And she basically turned to me, first day of internship. She knew I had worked in nutrition. She said, oh, you're interested in nutrition. We had a patient that had a BUN of 2, and she looked at me and said, what do you think about this? I said, oh, that's great. BUN of 2, that's awesome. She looked at me and said, I thought you knew something about nutrition. And it's clearly I did. And she's like, that's not great. I was like, I'm on the renal service. To me, it was like the lower the better, right? She said, no, that's not good. And I was like, oh, God, I just failed. But anyhow, so we have a clear definition, right, of chronic kidney disease. And this is kind of my theme here. We know that, obviously, end-stage renal disease increases mortality. Dr. Wagner, is Dr. Wagner here? She's at the VA probably. Hi, Dr. Wagner, if you're out there. So anyhow, so Dr. Wagner is my VA clinic attending, and she, she was great. But one day I said, I want to learn all about hypertension. I'm going to read JNC7. And she said, knock yourself out. That's your topic for next time. I didn't realize that JNC7 was like a zillion pages. She said, I want you to read the full report. I said, oh, yeah, no problem. I was like, it's a paper, but it's a huge book. We have a diagnosis definition for hypertension, right? It's really specific. Dr. Bornstein, we have definite definitions of diabetes, right? So you kind of see the theme. And we know that it increases risk. These are things you guys know. But malnutrition has no defined definition, well-defined definition, and that's a problem in our nutrition world. We do have some, and I'm going to go through some of this, we do have the ability to identify people that are at risk, and we have a number of measures that actually can look at risk in malnutrition, and I'm going to go through those. Now, the one that I'm really interested in now, I do a lot of outpatient, and I know you guys do too in the internal medicine world and medicine in general, but I'm actually interested in sarcopenia. And this may be kind of a little subset of malnutrition that we do have a good definition, and there are ways to measure it, and that's going to be the second part of my talk. My learning objectives. So I'm going to go through kind of the difficulties. I've already kind of brought it up, the difficulties of defining malnutrition. I'm going to talk about nutritional risk. I'm going to use a couple cases from my practice. I'm going to then talk about sarcopenia and have you guys identify and be able to diagnose and treat sarcopenia in your practices as well. So do the definitions matter? Does the definition of malnutrition matter? Well, it certainly does. This is from 2009, 2010. These California hospitals were basically diagnosing people with kwashiorkor, which obviously is very rare in the United States, and they were diagnosing it at a high clip. 16% of their patients they were coding as this very rare nutritional disorder we see not in the United States. And so obviously Medicare came after them and said, look, this is not correct, and they fined them millions of dollars. A follow-up to that, they also were diagnosing people with severe malnutrition at a high clip compared to other hospitals in San Diego County. So definitions do matter. Malnutrition, though, is a wide spectrum. There's lots of, again, there's different disease processes. There are rare, marasmus, kwashiorkor. We have malnutrition associated with chronic diseases like COPD. So there's lots of area within our malnutrition world. Now, this is intentionally a horrible slide, but this is ASPEN. This is our American Society of Parenteral and Enteral Nutrition. This is our definition of malnutrition. You can see that, unlike those other definitions I gave you, I mean, it's pretty busy. They break it down by acute illness, chronic illness, in the context of social and environmental circumstances. And look at this. I mean, interpretation of weight loss. It's really busy. And that's why Steve's probably, his stomach's kind of churning right now because he's like, this is just not a good, solid definition. Plus, in the ICU world, it's like, how do we measure body fat, muscle mass, fluid accumulation, reduce grip strength? We don't. That's the problem. So some of these things are tied to our definition that it's not practical to do in a hospital setting. Now, I will say that I'm coming around to this a little bit more, especially in the outpatient setting, and I'll go through that eventually. The big question again, how do we measure these things in the ICU? We don't do it very well. ASPEN, I think, so one of the benefits of my job is I get to go to Europe every year because Mayo feels like, boy, we got to have you educated on, keep up to date on everything, so I get to go to Europe every year. I know that I shouldn't be talking about that, but they send me to Europe every year, which is pretty neat. So this past year it was in the Netherlands. But Europe actually, because of where their system is set up, they basically, they do cutting-edge research in nutrition, whereas we don't do as much really cutting edge, in my opinion. And so they came up with their own definition, which I think is a little bit more reasonable. You start with a BMI less than 18, that person's malnourished. Now, it's not a great definition. Then they have alternatives where they incorporate weight loss and other things, but a little less busy than our ASPEN, American Society definition. We came up with our own, so this is how crazy it is. It's like everybody's come up with their own definition. That's one of the problems. So before I got up there, our nutrition people at Mayo didn't like any of those definitions and just decided to come up with their own definition, which doesn't really, I don't think, help matters, but a lot of institutions do this. This is for coding and billing, really. This helps us with coding and billing. So if we bill for moderate or severe malnutrition, we can eventually show the government, hey, we have our own set definition. We follow this. It's our expert opinion, and we may not get fined like those California hospitals, but I don't think it helps us much. One of the things is ICD-9 versus ICD-10. I mean, like ICD-10, like they now have left, little toe fracture. It's like they've expanded the codes exponentially, and so they didn't do that with malnutrition, though. You can see that they left these definitions pretty much the same. You can notice that kwashiorkor should be rarely used in the United States. That's kind of what they tell you, and the California hospital didn't really listen to that, but anyhow, so they left these the same. One of the thoughts is they left it the same because we just don't have a unifying diagnosis and definition. Will we ever agree on one? I don't know. Going to the European meetings and the American meetings, I don't know if we'll ever agree on this. But what we can look at is nutritional risk, and that's what's important for our patients, is to figure out who's at risk for malnutrition. How can we identify those individuals? So I'll give you a little case. This is a real case, and I'm making this up. So this is so I took over this job as one of the first patients I saw after taking over this job, And so it was a little overwhelming. These patients are pretty sick. They come in pretty complicated. But this is a 33-year-old with a duodenal switch, which is rarely done now. Weight loss was, as you expect with a duodenal switch, pretty significant. She got down to about 180 pounds, when we saw her, and that had been stable for about a year. Her oral intake for her, which I rarely believe them when they say, "Oh, I'm eating normally," but for her it was pretty stable. In the past couple months, she started to lose some. She had increased loose stool. She had fatigue. She had cognitive problems. She had edema, and she had blurred vision. So on my exam, she definitely had temporal wasting, kind of a sign that she's malnourished. She had edema. She had alopecia. I ordered a bunch of labs. Just click a button in these labs up here, which is kind of neat up there, and they do them pretty quick. So the question is, does this patient have malnutrition? And something you should ask yourself. If you look, her BMI is 24. Most people would say, hey, that's not malnutrition. And in fact, all the previous definitions I showed you wouldn't have picked this up. Her weight's stable. Again, no weight changes in the past 3 to 6 months. Again, the previous definitions would say she's not malnourished. We didn't have any lean body assessment back in 2014, so pretty much, you could argue, boy, she's not really malnourished, but your brain tells you all the things I was telling you in that case, well, she's malnourished. But you certainly know that she's probably at risk for problems with the malnutrition, right? That's why she came to see us, because other physicians had identified that she's in trouble. I'll get back to her. We'll finish her case in a bit. So are we asking the right question? Malnutrition, is it the right question? Really should be asking who's at risk. And so we're going to go through that a little bit here. And so obviously we have starvation-related malnutrition, chronic disease-related malnutrition, as well as acute injury causing it. So key points for nutritional risk. Not all patients really respond to nutritional therapy in the same way. It's this whole individualized sort of movement we have. The benefit of nutritional therapy, right, depends on a number of factors, including risk, also route of therapy. I do a lot of home TPN, so I do a lot of TPN, but obviously my first goal is to get these patients enterally nourished. Who benefits from the nutrition is another question we have. So nutritional risk, the concept of this is there's minimal benefit expected if you're a really low-risk patient, right? Nutrition, as pro-nutrition as I am, it's not going to get people that are severely injured and wounded or ill. It's not going to get them to magically jump out of the bed, right? It's not magic, but certainly it's more likely to benefit those that are more sick. There's a number of screening tools. I'm not going to bore you with a ton of these. I picked 3. There's like 70. But they're good. A good tool, right, is easy to use. I'm going to show you that some of these tools aren't easy to use, and that's a problem with them. This is one of the tools that's well known. It's the NRS 2002, obviously done in 2002. This is for hospitalized patients. And you can see here, if your patient's admitted to the hospital and you're trying to screen them for malnutrition and complications from malnutrition, there are a number of things on here that certainly you're going to get points for. And if you go to the end, if you're greater than 5, that's a really high-risk patient. If you're greater than 3, that's a patient that you would consider using enteral nutrition or parenteral nutrition in. Everybody wants to come up with their own, nutrition risk score. So this is by Darren Hyland out of Canada. It's Nutrix score, and this just shows you somebody that's maybe not seeing patients on an everyday basis, right? They added this IL-6 measurement. I don't know. I can't do IL-6 at Mayo Clinic. I don't know if you guys can hear. Craig McLean can in his lab, I'm sure. But it's like just shows you that some of these were developed a little bit in a vacuum. But you can see that, obviously it takes into account Apache score, SOFA score, comorbidities, and age. And if you're 6 to 10 points gets you high risk. These are people you're obviously going to think about artificial nutrition. Now he went back and he actually did, probably from critiques from a lot of us, said, look, if no IL-6 is available, it's not available anywhere. So he came back and redid his score. So this has been validated most recently, just this year and last year. They looked at this, and what they basically, in general, found was greater nutritional intake in these high-risk patients was associated with lower mortality and faster time to discharge alive if they're high risk. The NRS 2002 has also been looked at in hospitalized patients. And just to make a point, this one was in ICU patients. So that's been validated in the ICU setting. This one's been validated in the hospital setting, not necessarily the ICU setting, but the same sort of thing. If they looked at people and they found the ones that are high risk, and thus, because they're high risk, again, you consider giving them artificial nutrition either through enteral nutrition or parenteral nutrition, first enteral nutrition if you can. And what they found was the ones that got nutrition did better, right? You know, all these outcomes were better in those individuals. They got a little bit more protein, they got more kilocalories, and they did better. This is the last one I'm going to show you, I promise. So this one actually, though, I like because it can be used both in hospital as well as outpatient setting. It's been around for a long time. So we actually have been starting to use this in our patients that are ambulatory before they get hospitalized. It's really 6 questions. M&A, it's been validated. I'm not going to show you all the validation. It's been validated a ton of times. It's been around for a while. But it takes into account a number of factors, including neuropsych problems, psychological stress, mobility, weight loss. So some of these things that I see in the ambulatory population. So back to my case. So this lady, again, just a reminder, she had duodenal switch. She came in to see me. Weight loss was stable. BMI stable, edema, diarrhea, blurred vision. So some of our labs came back. We get, again, like I said, we run them at our place, so we get them pretty quick. So all these labs came back almost, pretty quickly. The one that was ordered by the endocrinologist a couple days prior was the fecal fat. You can see from these labs, her phosphorus, that's normal. K was low normal. Calcium's low, but if you look at our albumin, right, our albumin is low. So that actually corrects. Total fat was 121 grams. That's a lot, by the way. Normal is 2 to 7 grams per 24 hours, so she's malabsorbing. Folate's pretty low as well. INR, or PT, was elevated as well. So again, the same questions. Does this patient have malnutrition? Absolutely. Even though your definitions of malnutrition want to pick this up. Even our Mayo Clinic definition want to pick this up. So what's the next best step? You always think about what's the next best step in the management of this patient. So what the next best step is, and probably what I did is a little different. So I would have said the next best step now, looking backwards, was to admit this patient and probably start TPN. She cannot orally maintain herself. You can try oral nutrition. That's what I did because that's how I've been trained. And what happened to her was I said, okay, enteral nutrition's first. We got to do enteral nutrition. I got to get her eating. I got to get her. So we worked with her for basically a couple hours. We got her, okay, we actually got her supplements, nutrient supplements. She did those 4 times a day. She increased her enteral nutrition significantly. What happened was she did that for a couple days, and then she came back and was admitted to the ICU for respiratory failure and hypotension. Her weight had increased acutely by 8 pounds. Her edema worsened, and she had to be admitted. Here's her labs. This phosphorus level was after her ICU replacement, too. So phosphorus, that's really low, by the way. But it was probably even lower than that. Her potassium was low as well, and they were having problems actually replacing this. They were trying to keep up with this. The labs I'd ordered had come back at this point. Her vitamin A, remember she was having night vision problems, right? Night blindness. Her vitamin A was pretty low. Vitamin E is low. This is one of the lower zincs I've ever seen. I'm sure Craig's probably seen lower. Copper is pretty low as well. This lady was severely malnourished. Again, our definitions wouldn't have picked any of this up. What's the likely cause of respiratory failure? So think about this. Obesity-associated hypoventilation. I put some silly things up here. Pulmonary embolism. I don't write good questions. And then I had this I'm a physiologist, so I had this is obviously clearly the answer, right? All right, but I don't name it. So what is that? What is that commonly known as? Okay, so I heard some of it maybe, but if you don't know it, like Dr. Roman, I'm a history nerd. So anyhow, I only have 4 history slides. But I'm going to show you where this came from, or where it was really studied. So this is Bergen-Belsen. This is a concentration camp. And the unfortunate thing about this concentration camp, and it's bad to say it like this, they didn't have gas chambers. So these individuals starved to death. They basically starved these individuals. And when the British liberated this camp, 14,000 died following liberation. The last couple of months, inmates were fed about 400 calories per day. After liberation, and I actually got to go to Oxford to give a talk about this, which was pretty cool because they heard I was interested in this, and so they invited me to give a talk. And so the British actually had taken a pounding in the media recently in the last few years because they kind of looked back and said, you didn't care about these individuals. And so when I researched this, I basically found out, boy, if the United States had liberated this camp, they would have done a lot worse. Because the British had actually trained nutritionists to deal with this. They had experience in India with the Bengal famine. So they were the experts in nutrition. They developed ththese protein hydrosylates. But anyhow, so these individuals, when the first soldiers came through, they were given K rations and they were dropping dead with just their first mouthfuls of food, which seems a little crazy, but that's what they described. And so 2,000 actually died after being fed, I'm trying not to say it, being fed high-calorie rations. These protein hydrosylates, these individuals, the Nazis would actually inject them with gas in their veins so their bodies would burn close to the end of death. So when the British said, "Hey, let's put these IVs in," the concentration camp victims basically said, "Don't do that." So they figured out this phenomenon of these individuals dropping dead with just a few mouthfuls of food. And what happens, they had limited rations after the first waves. And so what they did is they said, okay, we're going to limit the rations. And then what they found was these people actually were doing well. They weren't dropping dead anymore. Careful control of the volume, too, they found that it made it so these people didn't swell up. And they really figured out how to feed individuals that were in this situation. I actually discovered this in a corner of an article from like 1950, which is pretty neat. And so they basically figured this out. First phase, second phase, third phase. 800 calories for 3 to 4 days. Second phase is 1,700 kilocalories. And third phase is 3,000 calories. So it's like a gradual increase of calories. So this is refeeding syndrome, right? For the residents, this is a common board question. I always saw it in the in-service exam. It was one of the few that I felt pretty comfortable with answering. Probably still answered it wrong. You know how those things go. But it's one of our, in nutrition world, it's one of our, from now nutrition, it's our biggest risk that we worry about, right? My lady that I sent home on enteral nutrition that I probably should have admitted and either tried enteral nutrition in the hospital or initiated TPN, she was refeeding syndrome. The thing about the syndrome is, you guys may not see the syndrome, right? Dropping in phosphorus isn't a syndrome, right? Giving nutrition and then having a drop in phosphorus, that's not a syndrome. Syndrome is a constellation of symptoms, and so this is the full syndrome, right? So you may see somebody that when you give them nutrition after they've been starved a little bit, you'll see their phosphorus drop, but they won't progress to what my patient was or the full syndrome, right? So I have doctors tell me refeeding doesn't exist, but it does exist. I'm a physiologist. I'm not going to go through the whole cycle here, but basically you get these individuals that have protein breakdown. They've been starved, like those individuals at Bergen-Belsen for a long time. And then when you introduce them to nutrition and high calories, you have this immediate switch to anabolism. So the anabolic process occurs, and basically that's what happens. You get insulin surge, and eventually you have uptake of glucose, potassium, magnesium, phosphate, and then in your serum it just becomes devoid of these electrolytes, and you get arrhythmia, death, these sort of things. So one of my themes is looking at risk, right? So there is a risk calculator for refeeding, and this is one that I use quite a bit. Is it great? No, but it's pretty good. But looking at this, my patient, I may not have even picked her up because her labs were pretty normal. Her intake, she said, was normal. So yeah, this may not have been something that I would have picked up on my first case I gave you, but it's a pretty good way to screen your patients, either in an outpatient setting or in patients that may be at risk. There has been a recent randomized controlled trial. This is Gordon Doig. He's an interesting guy. He's got the rock eyebrow raised, and that's kind of how he acts. He's kind of a bizarre guy. But anyhow, he did a randomized controlled trial of refeeding. And basically, I had problems with this trial because, boy, these patients were actually refeeding. So like my patient, they were refeeding, and then he randomized them to get either full nutrition or low nutrition. Again, I showed you at Bergen-Belsen, they figured this out. They figured out that, boy, if you give them high calories, they die. So if I was an IRB, I would have problems with this. But this is, in his defense, we didn't have a good randomized controlled trial on this. And so basically, he took patients that were refeeding within 72 hours, so low phosphorus levels. This is probably where my patient was. And he randomized them to standard calories versus restricted. And here's his restricted plan. It's kind of, he ramps it up slowly. If the phosphorus is okay, then he can continue to ramp up. If it drops, you got to back it off. And what he found was hospital discharge status. So standard calories, you were discharged less likely. The mortality was higher than restricted calories. And that was significant. And that actually persisted to 90 days post-discharge as well. Length of hospital stay was different. ICU length of stay and a lot of the other ICU outcomes were not different. So to conclude my case, so patient was on PN for 4 months. Okay, she had common channel lengthening. She had her duodenal switch for revision. Albumin actually normalized. Now, normally albumin is a horrible marker for nutrition. This lady's CRPs were normal as can be. This is somebody that albumin actually was a pretty good, helpful marker. But I want to just caution you on using albumin routinely. Steve's probably going to throw darts at me by saying that this actually, in this situation, it was a legit low albumin. It wasn't like it was a negative acute phase protein, right? You know that if you have lots of inflammation, your albumins can drop. Her night vision improved with vitamin A, and her cognition. This is the cool thing about these gastric bypass patients when they need TPN is your cognition pops up pretty quickly. I don't know if that was vitamin B1 or what this was, but just general malnutrition. She was a different person in just a few days. So we took Bergen-Belson's their experience more so than Gordon Doig, the guy with the eyebrow. We took their experience and developed how we feed these patients. So these numbers aren't going to mean a lot to you other than we don't give them a lot of dextrose, right? Low calories. We give them lots of phosphorus up front. So if we know they're high risk and we've screened them for high risk, we will prepare for this and we will give them a formula that's ready for potential refeeding. I don't see much refeeding anymore based on this. When I correctly identify who's at risk, and we start nutrition appropriately, I don't see much refeeding phenomenon anymore, even dropping of phosphorus. We use that opportunity in this because we learned from my mistake why I shouldn't have sent that patient home that day. I was lucky something more severe didn't happen to her. But we use this. This phenomenon wasn't really described. There's another group in Europe that described this post-bariatric malnutrition that occurs that requires TPN. And so we looked at our cohort. We had a number of patients that had this, and they had wide-ranging surgeries. Most of them were Roux-en-Y. But the years the years between initial bariatric surgery and home TPN, 7 years. So this can happen to patients many, many years out. And usually there's some triggering event. I couldn't figure out what it was for the first case I showed you. But this happens sometimes years after their bariatric surgery. This is just showing you what we fed her. We fed her pretty much 7 days a week, and on average for our cohort, we fed them 7 days a week. There's just our calories. The big point is here that we improve their weights, we improve their BMIs, and their albumins actually improve significantly. And to me, this is probably the one case that I think about albumin and malnutrition. But again, caution you to use that only in situations like this. All right, so I'm going to give you another case. So I like cases. When I was sitting in the back of the room there, I was like, give me something that I can think about. So this is case number 2. This is actually a case that's sent to me from the University of Louisville. So 65 years, and I get quite a few of those now, which is great. I mean, if you need me, use me. And so I try to help out. I'm still gratis faculty here. But anyhow, so this is a 65-year-old and another Roux-en-Y, but it was for peptic ulcer disease, refractory peptic ulcer disease. But not surprisingly, they did this for refractory peptic ulcer disease, and the surgery is a little different, but she had weight loss, right? She went down to 88 pounds in 1997, shortly after her surgery. She then had revision, and she basically did okay, but she eventually developed chronic pain, like many of these individuals do. She eventually had a pain pump placed. She had a feeding tube. She did well on enteral nutrition, getting back up to kind of what her pre-surgery weight was. But then she developed this intolerance to enteral nutrition. And over the last 12 months before we saw her in October of last year, she was really struggling. The decision down here was to start parenteral nutrition, which I think was completely appropriate. BMI got to 15. Remember back on all those definitions, pretty much you would screen positive her for malnutrition and risk for malnutrition. Her PO intake had dropped off. It was difficult. The reason, you guys have great nutrition here, Steve's world-class nutritionist. The reason she was sent to us wasn't because of me. It was because of our interventional radiologist. And we needed to get a line for her. She had no other really options as far as central venous access. She had thrombosis everywhere. And they eventually got a crazy like branch of a femoral PICC line in, which she still has to this day, which is interesting. But so anyhow, so she didn't have central venous access. Here are her labs. The only one that's a little bit low as far as electrolytes, her magnesium at baseline is low. Albumin, again, another one of these post-bariatric phenomenons, 1.3. And I can tell you her CRPs, ESRs, I checked every inflammatory marker. Those are all normal. So back to the NICE criteria, right? So I'm going to try to get you guys to think about this eventually for your patients. She has them, right? Body mass index less than 16. Maybe not this because her weight's kind of been really low, but maybe over the last 12 months. Little or no intake for 10 days for sure. Low levels of magnesium for sure. She's at high risk for refeeding, right? So the next best step is the similar slide, right? So I learned from our mistake, actually, and this patient came up there, and actually I was down here doing teaching, and my colleague called me and said, hey, this lady is in rough shape. She hasn't had any intake. She couldn't eat. So I was like, well, let's just admit her, and we started TPN here. The decision already was made to start TPN because she failed enteral nutrition, and we admitted her because you'll see that some of her labs eventually were pretty bad. Now, on the way out, this is my pivot to my second part of my topic to talk to you guys about. On our way out, we had this new machine to look at lean body mass. Again, to define sarcopenia, which I'm going to talk about next, you need lean body mass. We also got a hand grip strength. And so I can tell you that this is pretty low and this is low. So on our way to the hospital, I had him get this. So that leads me to, what about malnutrition in the clinic? So we've talked a lot about hospital risk, but what about in the clinic? That's kind of where one of the interests I have. Like diabetes, NAFLD, obesity, sarcopenia can actually be defined, unlike malnutrition. It can be evaluated, defined, and eventually it responds to treatment. Couldn't find AIM. I couldn't find a good picture of the AIM clinic. Do they still call it AIM clinic? No, it's changed. Okay, so but I did find the faculty practice building, but anyhow, so. All right, so what's the definition of sarcopenia? So again, I write horrible questions. I just had to come up with some really bad ones. So the answer is here. So it's absolute muscle loss less than 2 standard deviations below a healthy individual, plus decreased muscle strength. So it's got 2 components, muscle loss and strength. It can be associated with age. It can be associated with liver disease. It can be associated with chronic kidney disease. It can be associated with a lot of different situations. So a lot of you in this room will see these patients in your clinic. It's associated with inactivity, right? We know this, and I'll show you a couple slides on bedbound and how it decreases your muscle mass pretty quickly. And obesity, sarcopenia, I'm going to talk about that a little bit. It's a plug for the ACP regional chapter meeting. I forgot where it is, but it's here in town someplace, but come to it, check that out. I'll give a talk on that tomorrow. So just to really quickly talk about sarcopenia and cachexia, these two terms aren't the same. That's one misconception. And so there's some differences here. I'm not going to dwell on these. So just know that they're different phenomenons. And here's the take-home for cachexia. Usually we see this, right, with cancer-associated cachexia. It's a multifactorial syndrome. It's usually associated with systemic inflammation, right? So that's the big difference between it and sarcopenia. The big plug here, though, is everybody assumes, boy, you're at the end of life or cancer is really raging. Nutrition won't help this. And that's probably correct. But I always tell people, get nutrition involved early when the patients are in the pre-cachectic sort of stages. Get them early. Oncology, I try to encourage them, hey, if you want us to come by and do nutrition, don't call us when it's the last palliative care option as far as nutrition goes. Call us earlier in the course of their treatment. So here's the European consensus. I kind of have a European bias for as far as stuff because I go there every year and learn about all the new research. And so they've come up with a definite diagnosis and definition. They have pre-sarcopenia, sarcopenia, and severe sarcopenia. Muscle mass, strength, and then performance. And so that kind of helps you. So if you have the diagnosis of sarcopenia, you have to have decreased muscle mass and strength or performance. And severe sarcopenia, you have to have all 3. And I'm going to show you in a second how we can measure this. So this is different ways we can measure this, different modalities. And bioimpedance DEXA, we can directly measure muscle mass. Hand grip strength, we can measure muscle strength. And then you can do like get up and go tests. You guys in geriatric clinic do these tests often. So muscle mass, unfortunately, it's kind of depressing. I'm 44. It starts to decline, right, in your third decade. And then after 50, this decline increases to 1 to 8% per year. It depends on the person and how active they are and other factors. Aging reduces muscle protein synthesis, a phenomenon called anabolic resistance. And this shows this. So basically, this is muscle protein synthesis as young individuals, old individuals, taking in a certain amount of protein. To get the same amount of protein synthesis, it takes much more protein in older individuals than young. So to overcome this anabolic resistance, older individuals need to consume more protein. This is and I'll show you a bunch of his stuff in a second. Doug Patton-Jones, I got to meet him, and we've been working with him on a number of things. But healthy, young, inactive individuals for 28 days, as far as they'll lose muscle mass as well. But look at healthy elders, 10 days of inactivity. They have 3 times the muscle loss in 1/3 the time. So just highlights the fact that, boy, as you age, you can lose muscle mass. If they're in a hospital, if they're in the nursing home and they're not active, they lose muscle mass pretty quickly. So what's the big deal about muscle mass? Why worry about it other than to look like Arnold Schwarzenegger back in the day? Muscle mass has been linked to all kinds of different mortality measures. And I'm not going to go through all of them, but when you have the lowest muscle mass, your mortality for cardiovascular disease is higher. Your all-cause mortality as well, when your muscle mass is in the lowest quartile, is higher. And so back to our diagnosis, the question should be, boy, how can I actually measure this? I mean, it sounds like, okay, decreased muscle mass, sarcopenia is bad. We see it in all of our patient populations. How can we actually do this? So back to my patient, her lean body mass, we measured that with the bioimpedance and hand grip strength, right? So we got her muscle mass, but we also got her strength. Okay, so those are the definitions of sarcopenia. So how can we measure this? We can directly measure this through a number of different ways. We have one of these at Mayo, but I never use it because, look, it's just so involved. I can't ever see this in the AIM clinic. I don't see it in our clinic. So the bod pod, get rid of that. So it really came down to DEXA and in-body or a electro bioimpedance is the machine right here. And this is expensive, technician. This thing, as I'll show you in a second here, you can do this pretty much in the office. This is actually our machine that we use. And I know there's a couple of these floating around the University of Louisville, or maybe at least one. I have a video, but the video is really slow. It's my colleague doing this. So this machine's easy to use. Yeah, it's going to go real slow, so I'm going to fast forward. I don't know why it's slow motion. It's like, This is my colleague, so I told him, I said, hey, I'm not going to be on being video, but could you get on this? So basically, you get on it, it weighs you, and then the thing walks you through, hey, how to do this. And it passes electrical current through you, and, initially I'm like, boy, this is totally made up. This is something, like quackery from way back when. But it gives you a report. It tells you, it gives you your lean body mass. It gives you a number of other measurements as well. But the main one we look at is lean body mass. Nephrologists use this actually in practice looking at, it's very sensitive for body water as well. It's got a visceral fat estimation, which hasn't been validated yet. So it gives you a lot of information. So bioimpedance in general, my training, I basically said, I don't believe that this is good stuff. And that's based on old technology, though. So the old technology just passed current and treated your body as a single cylinder. Now these newer machines break it up a little bit, and they're pretty accurate. So when I got to Mayo Clinic, I was a skeptic. And I was like, my mentors in nutrition, and I just don't believe that this is a good machine. My chair had actually bought one of these machines, sat me down, gave me all this. He's an evidence-based guy, gave me all this data and said, these things are pretty good. And I was like, oh, okay. So, so we did a prospective trial. What we did was we got 176 patients. The company paid for this, I'll say that up front. So they sponsored this trial. So we enrolled 176 patients into different BMI classes. So I wanted to see, do you lose this effect as the BMI increases? They fasted overnight just like a lab draw, and they got this bioimpedance, and then they got DEXA, which is the gold standard for body composition, immediately after. So you can argue, boy, there may be some distance in time, So we got this right after. Our primary aim was to look at, does the BIA and DEXA agree with each other? This is just all these were the same. This is table 1. So this is pretty interesting. So the correlation between the DEXA and this silly machine you stand on and you don't even need a nurse or technician to get was pretty high for percent body fat. That's a pretty good correlation coefficient. We haven't published this yet, but right? Lean body mass was even better. So this thing accurately predicts in kind of ambulatory patients lean body mass. Again, to define sarcopenia, you need this. Right? To diagnose sarcopenia, you need lean body mass. This machine does pretty well, even at high BMIs as well. So this, we found at higher BMIs for lean body mass, it does a pretty good job. The correlation is pretty high, even at BMIs greater than 35. There's other advantages to my nephews. I had some other slides in them. The ones that the University of Louisville recruit, I took that out, some of my later slides out for obvious reasons. But anyhow, so my nephews are really good basketball players. So athletes can use this, obviously, for hydration status. Cardiologists, nephrologists can use this as well. Hasn't been validated for visceral fat yet. So my case, the case that from the Louisville patient, the patient did well on home parental nutrition. The BMI improved, right, to 18.5. Doesn't seem like a lot, but, over basically 10 months. Lean body mass had improved. We got a repeat measurement. Her hand grip strength improved. So really, for me, I was seeing improvement with nutrition, right? Her sarcopenia actually was improving. And she now went from, probably because her hand grip strength improved. Remember, you need that for sarcopenia. You need both of these. She actually was in the pre-sarcopenic region. We put her into the pre-sarcopenic definition based on our treatment. Hand grip strength, again, these aren't great, especially in the ICU. I don't recommend doing this, trying to measure with like a scale, but these things are pretty cheap. Again, so the technology is there to measure and evaluate sarcopenia. So the real question is, how can we help these patients? So there's really two big areas. I got this 10 ways to stave off sarcopenia. The guy actually knows his stuff. This Dr. Axe, I've never even heard of him, but he has 10 different things on there, but really there's two big ones, protein and exercise. So I was lucky enough, I'm way back here, that's me. So these are world experts. So Craig was there and Steve were there, but this is like a really well-known group of individuals. And I highlight this because this is Stu Phillips and Doug Patton-Jones. These are guys in this area that are really well-known. So I got to hang out with them for a couple of days, which was pretty neat. And Steve and Craig, too. It was cool to hang out with you guys. So Doug Patton-Jones talks about how to improve sarcopenia with protein. And his general hypothesis is throughout adult life, consuming adequate amount of high-quality protein each meal in combination with physical activity may prevent or slow the onset of sarcopenia. And he has this 30-30-30 rule where you consume 30 grams of protein. I'll show you why that is in a second. Include high quality protein options for your patients, and then perform physical activity in close proximity to delivering the protein. We know that higher protein intake has been shown to decrease the loss of lean body mass. That's been done in a number of studies. The higher amount quintile of protein you consume, the less lean body mass loss you have. But it's not just about more protein. It's about how you deliver it. This is kind of a standard American diet where you eat breakfast, you have a bagel, some coffee, very little protein there typically. Lunch, you'll get more protein. And dinner, we eat a ton of, in American diet, we eat a lot of protein at dinner. Now, the problem is you reach a point where you maximally stimulate the ability to lay down muscle. And so this stuff just goes above and beyond. You probably waste it, right? So his strategy is more, let's consume equal amounts of protein to get you up to maximal protein synthesis. So that's his 30-30-30 rule. And some people will actually do, I think I have it somewhere in my last couple slides, some will actually do 30 right before bedtime as well. We've changed our recommendations quite a bit. 40% of those over 50 do not consume an adequate amount of the RDA recommended protein. Right? And I told you about anabolic resistance. So these individuals that are older, they become more resistant to protein anyhow. So they really are at risk for not getting enough protein, even by these standards. So all these international groups have pretty much increased the amount of protein intake that we've called for. Our protein summit did as well. So we said, look, we've got to increase the amount of protein. Now, there are some older individuals with severe kidney disease, not dialysis, right? Dialysis, they need a ton of protein. That may need to limit protein intake. For those individuals, you give them a normal amount of protein, 1 to 1.2 kilograms of protein, grams per kilogram. There's a lot. I always get to ask the question, what protein source? To me, whey protein probably is the best when they've looked at this. But animal sources of protein tend to be, in general, better than like wheat sources. And so the protein digestibility is about the same, but the biological value increases as you go up here, with whey probably being the superior. So you'll see the body, the muscle heads will be all on whey protein because of this. So resistance training, right? So this has become something that when I was in training, we talked about this maybe a little bit, but now in nursing homes and nursing facilities, you'll get these individuals who will do resistance training to help try to help with the sarcopenia. There's been some studies. There's been some randomized controlled trials. There's a ton of them in this review if you wanted to go through them further, but I picked out a few. But I picked out the long-term one. So this one was frail community, mean age 83, randomized to progressive resistant exercise training versus low-intensity exercise for 9 months. They used the DEXA, so the lean body mass was significantly greater in those that had exercise. Okay, that's kind of common sense. This one is another one as well. It's 246 patients, mean age was 69. They were in like a assisted living situation. They were randomized to resistance training versus kind of a well-being program for 18 months. And their primary outcome was lean body mass, as well as they use strength too, really, to get at that sarcopenia. You got to have right mass plus strength. And they also did performance well, the time up and go test. All outcomes were significantly improved with resistance training. So the bottom line is get your older patients to do just bands. You don't have to get them to go to the gym. Light weights, resistant bands, do it 4 or 5 times a week. It can really make a difference. What about exercise plus supplements? They looked at this, 100 nursing home residents, 87 years old. They got them as placebo-controlled trial, resistance training plus or minus supplement. The problem here, the supplement was a 15, I won't name the company, but 15 grams of protein once a day. So I was showing the earlier slides, that just probably is not enough in general. That was in addition to what they're eating. So what they found was exercise improved muscle strength. Exercise plus supplement even did better. Supplement alone didn't have much difference as far as strength goes. Yeah, just a couple more slides. So this is another guy, Stu Phillips. These guys were great. I really loved hanging out with these guys. I'm gonna give him grief next time I see him because he's all over the internet. It's kind of funny. He's a real famous guy in this area, but he's on all these biohackers and mythbusters and these sort of things. But he's a really nice guy, really smart, and he's in this area. So the timing of when to deliver your protein, 30 grams following resistance exercise training will help after you're breaking down your muscle with resistance training. Giving the nutrition afterwards has been shown to actually help lay down muscle. And so this is what this shows. So this is basically, this is the breakdown when you're doing resistance training. Give your protein right afterwards, and it really helps with the maximum protein synthesis. So my conclusions, again, the last time I did grand rounds, one of my big take-home points was measure BMI. You can't diagnose obesity unless you have BMI on the chart, right? So my take-homes here is more for sarcopenia, right? I want you to use these screening tools I talked about early on instead of that definition of malnutrition. Until we get a good, really solid definition, use nutritional risk, right? Use refeeding risk. Use these risk calculators until we, as a group of nutrition professionals, come up with a better definition for you. If you can, and you have one of these machines here, by the way, at University of Louisville, I'm not going to say where because that person will probably kill me because now you start using it all the time, but you have this. These do cost a little bit of money, but they're $10,000 up front, but look, it costs nothing. I don't charge my patients to do this. It costs nothing to run it afterwards, right? You can hand grip strength. You can actually really make a difference in these people's lives, these elderly sarcopenic patients, by measuring and then targeting your treatment, right? Like if you measured blood pressure, if you didn't measure blood pressure and you just put people on medication, it doesn't, it's not optimal treatment. Deliver high protein, higher than RDA to elderly sarcopenic patients. I think it's a pretty safe recommendation. 1 to 1.2 grams per kilogram, 3 to 4 times a day. And then resistance training. Get your patients doing resistance training. Start them slowly. If you tell them go home, do 5 days of bands or weights, they're going to come back and kill you because they're going to be sore. So I start on one day a week, and gradually increase them, to light band activity or light weights, 3 to 5 times a week. Follow the delivery, talk to them about this. I counsel them and say, look, after you do the bands, go get yourself something good to eat. The problem with the supplements is, for residents, when you say, oh, go take this nutrient supplement, right? The problem sometimes with those supplements, they don't all the time taste good to everybody, right? I don't think they're that bad. I used to feed them to my rats. But in general, taste is a problem for some of these individuals. Say, look, and then you tell them to go do that, and they'll be embarrassed. They'll come back and say, they won't tell you that they're not doing it, right? So if they don't like the supplements, get them on real food. I like real food, right? So those are my take-homes for you. This is my wife. When I told her what I was going to talk to you guys about, she's like, "Are you kidding me? How boring is that going to be?" So hopefully I didn't bore you too much. This is my daughter with our dog. My sons. This is Yasmin Shaw. She was the chief resident with me. So every time I come here, I think about her because she really kept me straight. She was the more organized of the two. I was kind of the academic nerd, and she was highly organized with Jen Cook. Tom Frazier. I was talking to Dr. Redger about flying around Vancouver earlier. A couple years ago, we went to Vancouver and did some touring up there. So it's truly an honor to come back, and certainly I'll take any questions you guys have about this topic or anything else.
Thank you, Ryan. You can tell your wife that I said this was not boring.
Okay, thanks. She'll be happy about that. She's like, God, you got it.
Before I ask you a question, I want to remind everybody that the Untitled Chapter ACP meeting is on Friday at the Chelsea First Campus. So we welcome there. The residents and other people are going to be there, great speakers and so forth. So please join us. I want to have a question before I open it for the audience. And you mentioned your physiology. So why is it that as we age, we get into this problem? Is it mitochondrial function? Is it immunology? What is it?
Yeah, it's probably a combination of a lot of factors. Activity is one, obviously. Hormones is another. Hormone replacement has actually been beneficial in men, not as much as females. So postmenopausal, the muscle mass decreases. You've seen these ads for like these nutrigenic individuals, the physician that takes testosterone and basically is buff as can be. So some of it's hormonal, some of it's just decreased activity, some of it is anabolic resistance. So it's multifactorial. There's probably not one key thing. I didn't talk about any about hormone replacement, but that's certainly something that a lot of people want to do. Right? The baby boomers all want to continue to be young, so everybody wants testosterone nowadays. And so that's one of the common questions I get is, hey, if I do testosterone, my muscle mass increases. Well, yeah, probably, but there's other problems with that. So I usually start with protein supplementation and these sort of things and exercise before I go to those routes.
Okay. Chris?
Yes. Yeah, good question. Yeah, sorry I cut you off, but anything else? I'm sleep deprived. I got in at like 1 o'clock, so I got to remember Dr. Kruger's question here. So there's a wide range of these bioimpedance machines. I showed you a really good one, and you have one here at the faculty practice building just like this that we've got. There's a wide range, and there's a wide range of how accurate they are. So kind of the ones at the grocery store aren't going to be as accurate. But I tell you what, if a patient just, like it's a scale, right? Some scales are very accurate, some aren't. It's the same sort of principle. But I say if a patient can use it as a baseline, and use the same device, a lot of times that can be helpful, even the ones that aren't as accurate. But this, again, the machine, I think it's $10,000, but now I can use this for many, many years. I don't charge patients. It's just electricity to run the stupid thing now. So it can be a big benefit, a little bit of cost up front. It's really easy to use. The ones at the grocery stores are really easy to use as well. So.
Questions, comments? Steve, the older generation of biological people with food chips. In this newer version, how much air is introduced if the patient's dehydrated or overhydrated?
Well, two things I'll say about that. I think that is both a problem but also a benefit of these machines. And the nephrologists, the cardiologists for heart failure are using this. to know when their patients are volume over. The athletes are using this when they're hypohydrated, dehydrated. It's very sensitive, like you're saying, to fluid shifts. But it can be a benefit as well. But as far as the estimating lean body mass in those situations, it still does a pretty good job despite the edema. So that, yes, you're right. The older generation, and that's kind of what I was taught about. They weren't that good, and they really were problematic. And for your world ICU, they're coming up with portable versions of these machines now. Back in the day, ICU and even the LTACs, they're not good, right? So my ambulatory patient to do sarcopenia in elderly adults, pretty good tool. No, yeah, so that's a common question. And again, I'm a kind of a pretend protein biologist. That's a common question I get. It's like probiotics, like which probiotic do you use? And that's another question that's pretty difficult as well. I don't have a specific, but the problem is when you look at some of these protein isolates, sometimes it's not 100% whey, sometimes it's a mixture of whey and soy. I do prefer whey and casein versus soy. Soy has problems with inflammation. I've got a bias towards soy protein sources, but it's still pretty a decent source as well. But I don't have a specific brand or any whey protein. The guys that work out a lot, boy, they get religious on their whey source, right? They say, look, I'm going to only use this brand because it's the best, and it's like it's not really driven by any science. It's just what they like and what they found to work for them. And those guys, the guys, bodybuilders have figured this out, right? There's a reason they can get ginormous. And the reason is because they consume protein during the right timing, they consume a lot of it, and they lift like crazy, right? Yeah. So this is just a mild electrical current. So typically for those situations, it's been pretty safe. We don't recommend it for like pregnancy, but it's probably okay for pregnancy. It's like light current. It's pretty safe. Pacemakers, there's been some concern, so they'll have some, you say, well, maybe we shouldn't use it because we don't know, But I think theoretically it's probably okay in those situations as well. Yeah. A fall, yeah. And what you're doing there is you're making them worse, right? By keeping him in the bed, I showed you that slide. You're making things worse. So I'd actually argue by doing that, you're putting him at higher risk. I would basically say, look, you kept him in the bed for fear of fall, but you actually made it higher risk for fall. Mayo Clinic, I don't think you guys are as good as we are. I mean, there's nothing magical about it other than some of our specialists, and boy, I can get labs in 2 seconds, sort of stuff. I think you guys do just as good as, and you got Steve McClave here, who's one of the best nutrition people, who's aware of this phenomenon as well, and you guys encourage people to try to get people up. The surgeons, I think, do a decent job here, but as across the country, we do probably suboptimal job of mobilizing patients because of exactly what you're talking about. You had one fall, somebody broke their hip, you got sued. Our nursing policy says we're not doing that anymore. You got to get buy-in from nursing, physical therapy, right? It's not just the doctors that say, hey, get these patients up. You got to get buy-in from everybody. At our place, nursing has their own administration, structure, and it's a little crazy. I'm very pro-nursing, but like sometimes they have these policies that they'll get passed through that just make no sense at all, and it's really a big barrier to what you're talking about.
I was impressed with the chocolate phosphate. Your first study had pulmonary fellows are often told in the ICU that you can't wait and make sure your phosphate is okay because it affects predominantly with muscles.
Mm-hmm.
I don't know how much this contributed here, but it was a tremendous phosphate.
Right. Yeah, and I bet you if you looked at her diaphragm, right, one of the things we know with refeeding, sometimes some of these people that probably at Bergen-Belsen that ate and refed, they didn't just drop dead from mouthfuls. They probably actually, a lot of them died from pneumonias. They just can't guard their airway. The diaphragm's not, it's a muscle, right? So one of the things I think about as a physiologist is, boy, that diaphragm muscle is probably just totally inadequate, and hopefully that will build up over time. But yeah, the phosphate can drop in these people pretty rapidly and quickly.
Well, Ryan, we have a tradition.
hear that we give a bat to great speakers who come from the outside, who are really not from the outside.
I'm not.
So I'm debating.
You're going to keep the bat? You should keep the bat. You should keep it.
But it has your name. And so
Oh, okay.
what am I going to do with it now? But we really appreciate you and appreciate what you're doing over there, and that you come here, and that this is home. And thank you for that. Lionheart Medicine Grounds, University of Louisville, September 28, 2010.
Thank you.
Thank you, everybody. Have a good Thursday.